Good evening, everyone, and welcome. I'm Dr. Peter Laskarides, President of the EPA. Before we begin, I want to make note that the views expressed in this webinar are the personal opinions of the participants and don't represent their institutions or that of the EPA. The information shared in the webinar is for informational purposes only and should not be considered as professional medical advice. Additionally, we would like to disclose that this webinar is being sponsored by Upside Health. We're grateful for their support in making this event possible. The content and discussion will remain independent, focusing on providing valuable insights and information to our audience. Now that we've clarified these points, let us begin. Today, in the setting of a much evolved nature in which we provide care to patients, technology, and virtual medicine, I have the tremendous honor of introducing Rachel Traubman, the CEO and co-founder of Upside Health, a leading company revolutionizing chronic pain management. Rachel's personal journey and expertise in building digital products have uniquely positioned her to discuss the challenging and opportunities in this field. Join us as we explore Upside Health's innovative solutions, its role in the future of pain management, and the transformative impact technology has on patients' lives. Everyone, please give a warm virtual welcome to Rachel Traubman.
Hi, Dr. Laskarides. Thanks so much for that introduction, and I'm thrilled to be here today speaking with this audience, and I'm grateful to EPA for hosting, as well as to my esteemed colleagues who will be joining me later in this session on what's sure to be a very exciting discussion around the impact of remote care and digital health. My own disclosure, I am just presenting today as somebody who is very passionate and informed in this space, but nothing that I am discussing should be considered legal guidance nor a guarantee of any sort of reimbursement. So as Dr. Laskarides said, I'm Rachel Traubman. I am the CEO and co-founder of Upside Health. I am a seasoned entrepreneur and a one-time media executive who turned my attention to something incredibly personal when I started my company about 8 years ago. I've had the pleasure of knowing Dr. Mehta for about that length of time and collaborating together. The companies that I've started have been NIH funded, patient facing. I've received grants from Yale, as well as worked together with Cornell on a myriad of things, and have worked with both patient education groups as well as some pharma in understanding and supporting the space. And my company, Branch Health, is now actually, as of I think yesterday, in 10 states, has worked with almost 40,000 patients, dozens of clinicians across the country, and is integrated in 6 EMRs and counting. And Branch Health is a better remote care solution specific for pain care. So we help remotely assess, monitor, and support people in pain and those who care for them. So for the sake of tonight, when I'm discussing remote care, there's actually a myriad of things that fall under the concept of remote care. There's telehealth and virtual visits. Most of you, I'm sure, have been using them. I mean, the pandemic kind of transformed how telehealth was used, how it was reimbursed. There's care management, these whole slew of codes that are known as CCM, but there's also case management, as you've seen in like the post-op or post-hospitalization process. There's pre and post-op check-ins and education. So how are patients prepared for surgery and how are they checked in afterwards? And then there is monitoring. So how and why are these things reimbursable then? Well, starting in around 2015, the Center for Medicare and Medicaid Services started reimbursing for remote services under the terms of chronic care management, chronic pain management most recently, remote physiologic monitoring, remote therapeutic monitoring, this alphabet soup of codes, which can be bundled together or billed individually for the tune of up to $200 plus per patient per month. Our services in general, based off of the MAC, the location, we can get up to, $280 per patient per month for, and why did CMS though offer codes that end up allowing for more billing for them? Well, because there's documented lower cost for those patients in terms of ER and hospital visits, especially for these chronic pain patients. So chronic pain patients are a great opportunity for remote care. That's why there's new CPM or chronic pain management codes that came out. And, chronic pain represents such a huge portion of the population, as you all know, but there aren't as many of you specialists as needed. And so being able to allow you to operate to the highest degree of your specialty, to be able to see and support as many patients as possible is one of the reasons why remote care is so going to be so important in the pain space. But also these patients require multiple touch points. Many of them are polypharmacy. Many of them have functional limitations, which make it more difficult for them to get into the office. And many of them require a multimodal approach, which is often really difficult to offer in that period of time. But we've seen and we know that all of these opportunity doesn't come without challenges. So we understand that, and we've seen that physicians, particularly mid-levels, are seeing 40 plus patients a day sometimes in 10 to 15 minute increments. And that a lot of your time, unfortunately, is spent, dealing with insurance reimbursement and pre-auth challenges, all in shrinking documentation or shrinking margins and spending more time documenting, all of those things that have nothing to do with practicing medicine. And so you're asking to deploy a new solution or something new when you're already having limited resources. And administrators are also facing the same extended challenges. And all of these things actually make remote care so powerful and such a great add-on solution, but it also makes it a little bit more difficult because an administrator who is already dealing with 6 different vendors may not have the bandwidth to take on a new solution. But a patient is very, very hungry for additional support. And they're experiencing a great deal of helplessness and frustration as a result of your pain, as well as being pushed through the system and really struggling with the validation that they constantly need, as well as a great deal of loneliness and isolation. And so, there we go. And so the way that we have seen success as a company, but also bigger than that, where we see the success of remote care and virtual care or extension of care is really on the focus of extension of care. So it is not a replacement of traditional care. It's not AI is going to take over the world and doctors are going to be gone. It is not a direct-to-consumer solution, particularly for this population where many of these patients are unemployed as a result of their pain. But it is giving them more of what they need and giving practices and systems more support in the care of these patients. But in order to answer that claim, in order to make something that's truly an extension of care, it has to be an integrated care and it has to be specialized for each practice, understanding the uniqueness of each workflow. And so the 4 keys that we see for a successful remote care implementation are: 1, EMR integration. Whether it is a full EMR integration with an app on the Epic App Orchard or API access to Dr. Chrono or ModMed, or something slightly more manual on the point of view of the vendor, but it feels automated for the doctor, it's essential. 2 is modeling existing clinical workflows. So we go for each client and spend a couple days and just watch how their practice operates. If you're going to be an extension of care, you need to know how their care typically operates. So that way there is, again, no confusion about who to do what when, but also if you're utilizing multiple products, streamlining them when possible. No patient wants to get a call from potentially your internal care management person and then, or patient navigator, and then get a call from your monitoring partner who doesn't know that they recently spoke to the care coordinator, and then they're frustrated. And then the last thing is really experimenting, iterating, and then over communication with our clients. And that doesn't have to be daily calls or daily text messages, but really creating this partnership for success and understanding that while there can't be always the same degree of experimentation within healthcare, there can be subtle modifications that greatly change impact. Just a quick anecdote, we discovered that our patient, or your patients, right, that were using the Branch Health platform were just getting stuck on the login. They could not remember their usernames. They could not remember their passwords. And we spent so much time helping them remember that. And we recently changed, which was not a big lift for us. Well, it was some lift for us, but the onboarding process to be purely text authentication. And it made the patients happier, it made the tech support happier. And that's an example of experiment, communicate, and iterate that can yield really great outcomes. And then this also goes and find that a successful program actually has a unified message. So all the templates, all the communication, all the patient education, all the patient enrollment is co-branded when possible, that it truly feels like something that your group is offering, and that it is not patients being pushed onto a third party instead of actually your practice or your program being able to offer this extended care service. So I get asked a lot, but how is this medically beneficial or necessary? Is this, I see how this can create efficiencies in my practice. I see potentially how this could yield new revenue opportunity or growth opportunity. But what are some real ways that this has changed care, created multi-level transformation? So one example is really in prescription modification or treatment plan modification. So in the case of a client in West Virginia, the patient was utilizing our app, entering a whole lot of just unique insights into their experience with their pain. And in their monthly conversation with their nurse, they were able to identify that their treatment worked for the first 24 hours, but the next 48 hours, the patient was like in intractable pain that required them to take breakthrough pain medication. And this had been happening for months. But it was that specificity of the response that when the doctor was able to see it, was like, well, I can put this patient on a 48-hour regimen. It's totally safe. It reduces the need for breakthrough medication. And it was one of the things that would not have come up in their 10-minute check-in because the patient wasn't able to clearly communicate that until asked the right questions. The second use case is just the ability in our practice in Pennsylvania to offer their patient new modalities. So our platform in particular gives patient access to a library of nutrition, mindfulness, art therapy, sleep hygiene, pain education, a whole group of self-management tools that they can use remotely, but also the ability to triage and avoid, ER visits in the sense where a patient was having a breakthrough pain episode and the doctor was able to allocate a certain amount of time on Monday for should breakthrough pain, issues arise, these red flag type of issues. And the patient had a call with one of our nurses on a Saturday and Monday that were able to get in. And, obviously that doesn't always allowed by, insurance or number of checks, but like when possible, the ability to do it. And nobody, the patient may have called the office or a nurse line on a Saturday, but may not have, because sometimes patients are suffering in silence. Just insurance documentation. So much time is unfortunately spent documenting and verifying insurance requirements. And more insurances are now requiring things like functional outcome metrics, COMM study, reports, ODIs. So really having all of that in a concise place that you are not chasing down, but as part of the patient's regular routine. We've also seen the ability for that to create justification around, treatment plans. Another growing use case, especially at our clients in Oregon, is the chronic opioid therapy, the COT monitoring. Being able to provide risk mitigation for these practices, as well as additional support for the patients. And so part of our process with those patients is making sure that we address the 4As, making sure that the patients have active COMM testing or scores on file, and being able to allow the physicians and their administrative staff to make sure that they're prescribing and monitoring these patients safely, effectively, and aren't opening themselves up to unnecessary litigation. And then the last is kind of obvious for us because we see it all the time, but is this patient success and satisfaction, this understanding that they have someone who is able to offer time. And, time, compassion as a service is sometimes what we say, but on average, our nurses will spend between 60 and 75 minutes per month speaking to these patients. And yes, it's not therapy, but for a lot of times the patients, it feels like it. And so being able to offer that and have it in a way that is reimbursed is incredibly valuable. So I just did a lot of talking, a lot of East Coast fast talking, but now I'd love to get the feedback and the conversation of some leaders in this space. So, Dr. Mehta, Dr. Lascaris, Dr. Wang, I want to start by asking, what I outlined a lot of challenges that the doctors that we work with face when thinking about digital health. And obviously I didn't talk about red tape, which is, I'm sure another huge one, but I'd love to hear your feedback on when you hear or think about the term remote care or digital health, what scares you? What are your hesitations?
Well, Rachel, thank you. Thank you for joining the EPA and, having worked with you for many years now and having collaborated with you recently up at Cornell Ithaca, you are one of the best assets to the field. And it's really exciting to have you join this particular webinar. For me, as a academic physician and a chief of service, I think a couple of things come to mind for me. Number one, given the challenges of the economics of these types of programs, it makes it very difficult to sign up for programs that we can't immediately quantify the benefit. And I think you've done a great job making a business case for something beyond just remote care management, but other opportunities where it can engage with our practice. And then number two, how do we trust and let go of the usual practice that we do, which is so much of answering patient calls and reassuring patients that their care is being provided by the doctor that they saw, and extending that to our nurse practitioners, extending that to our nurses, our fellows, our residents. There's always this patient concern and even our own concern that are they happy with the care that they are receiving that we would have provided ourselves directly. And I think that is one of the concerns I have for digital health, that as we expand, does a patient feel like they're left in the dust and sort of force-fed this type of treatment?
Yeah, I think that's a really interesting question. I'm going to just touch on it real quick before I pose so one of the things that we've seen is really practice specific. Does the practice as it exists have the bandwidth to provide that high level of service right now? And a lot of practices that we work with don't. They want to, but they still don't have enough people to be able to hold the patient's hands the way that they want to. But then second is, if they do, where are the gaps? Where are the communication gaps that if So again, that example I had about like West Virginia and the medication, right? It wasn't replacing the care, but what it was doing was bringing information to the practice that allowed them to then provide the patient with better care. So I think some of it is, information gathering at a level that's just not possible with human capital, the way that it exists within a traditional system. And I think then it's also a matter of building trust with the person, the company, the group that you're working with. How organic and what are your standards, right? If a company or a vendor or a partner can't reach your standards of care, then they are not a right fit. Because they are operating under your general supervision. Like in our case, our nurses operate under the general supervision of the physician. So if they are not operating to the physician standards and under their care plan, that is not the right fit. But it's good to understand that concern. I would say, Dr. Lascaredes, what other concerns come up to your mind when you think of remote care, digital health, all those buzzwords?
I think that sentiment of outsourcing and the patients feeling heard and is the most important thing, right? Just like that communication is probably the most important element. I look at this as a means for us, and as you communicated, for us to have even more data, right? Gathering this day to day. If a patient logs on and says, this is what their pain is, this is how it changed, this is how, whether it's cognitive behavioral therapy or some type of other technique has influenced it, right? Upon an actual in-person follow-up, I think it when done well, it only adds to the care that we provide when we're actually there. So I think taking the risk of outsourcing some of it has the potential to yield better care.
So cheating a little bit here, but before we got on, Dr. Wong and I were talking a little bit about missing the physical, and how the physical connection with the patient and the physical assessment really is, at the center of care. How do you think we can reconcile those two things?
Rachel, are you asking me?
Yes. No, sorry.
Oh,
yeah.
Thank you. I appreciate that. So just to recap, what we were discussing is that, really the core of the physician-patient relationship centers around certain things. In-person care still has a lot to provide. Don't get me wrong. I think digital transformation has been incredible, right? Access has improved. Its simplicity of care has improved. But one of the things you and I had discussed is that my main fear, and we've adopted a lot of digital transformation in our practice, but my main fear is missing that red flag. If we digitalize it and we do, lots of phone calls, text messages, etc., and not physically put our hands on our patients, how do we reconcile missing that one red flag that we may not have missed had the patient been seen in person? And it's interesting because I was listening to your answers, and you mentioned fit, and I think that's key. Finding the digital transformation that fits and represents your practice the best. And I think having, to your point, right, like you're talking about the nurses that help navigate for the patients. I think to your point, answering that question, just listening to our conversation, I think that is key, and finding the people that understand what you are. So that's like extension of practice. I think that might be the key, but I would love to hear more of your suggestions as well.
Well, I would say one of the things too that stood out to me when you were just talking again, right? I heard this before, but this time really stood out to me was the need to be able to see the patient, in person again, right? And I think that true digital health and remote care is not a replacement of that, but a supplement. So the patient who has been seen in person and we've assessed that it's not a red flag, but the patient is still experiencing challenges, being able to assess and acknowledge and understand perhaps what are like the psychosocial components that are driving this patient's continual pain, is what is detracting from the patient, or where's the resistance to them following a suggested treatment plan. Maybe the patient just lost their spouse and is feeling isolated and lonely, and that check-in from somebody who is certified and qualified is really what they need, or maybe they need both. And being able to offer both in a way that current regulations support reimbursement of, it feels like, why not be able to give the patients more for those who need it, if it's being offered. So I'm going to throw another question back to you, Dr. Wong, which is in regards to the problem, if there's any, with existing pain care that you see. What did I miss when I was outlining challenges that you all face on a regular basis?
I mean, you were pretty comprehensive, right? I appreciate that. I think you articulated our challenges well. We have a lot of challenges. So one of the things I was actually thinking about is the key to digital, and this is the challenge that we see in our practice, is it's a catch-22. Many of our patients who need digital healthcare delivery the most are elderly patients, are patients who have difficulty traveling to the office, et cetera, right? Whether it's telehealth, remote monitoring, et cetera, are also our least tech-friendly patients. And they're the ones who are most resistant and saying, hey, I could talk to you on the phone, but I don't want to get you on video, right? How do you suggest we approach that specific challenge and introduce it and kind of hold their hands along the way?
Great question. I mean, that's probably 60% of what we do as business. Like it.
And if I could interject an added question to that is, how does it relate to the requirements that digital health has been outlined for by state and federal regulation in terms of payment?
Right. And so, of course, so for instance, I get questions like, can we deploy a solution that's just text message based because somebody doesn't want to download an app? Can we offer this on a desktop? Well, no. So as of right now, the way that we've had to build our programs are within the confines of what constitutes software as a medical device and what constitutes software as a medical device, perhaps under enforcement discretion or not. And that's not things like text messages. But what we can do is create a user experience and a value that correlates with the patient's needs, and also bring those nurses in as soon as possible. So there are ways where, for us, we show the value without the tech and then bring the tech in. Or we show we do a lot of pretty much like grandchild tech support. So we say, have you ever looked at pictures of your grandkids on Facebook? Yes, you have, right? Then they do it because they see positive feedback, like they feel good when they do it. So if we say, if you can do that, we can show you how to do this. And then the idea that we're taking the time, whether it's on video call, whether it's phone call, whether it's in person, to do that really builds, again, like that high quality, that patient experience that you want to do. And I think that we're going to continue to push and explore how this can be done. How can we use echoes? How can we use, our app right now works with like talk to text, but how can we use echoes? How can we use other resources to make these reimbursable sources as successful as possible. We also try to get caretakers involved sometimes. And they're part of the process. They may be part of the onboarding, or they may be part of the education, or they may just be part of the check-in if it's okay with the patient. So trying to work within the confines. And then once they see the impact of it, right? Once you say, I unfortunately cannot see you more than once a month, but I can offer you this. And with this, I was able to get that, and that changed this. And I think that when you can tell that story once or twice, then that changes how you tell the story to the rest of your patients, because you're not speaking as hypothetically, you're speaking concretely, and patients can feel that. I don't know how we're doing on time, but I have one more question for you all before we open up to everyone else. And it's, what do you think right now would be most transformative in the way, and like, all of the value propositions I, threw out there for the way that you practice? What was the most exciting for you? Where do you think remote care or virtual care can be most transformative? And then if you don't have an answer for that now, where do you think it will be most transformative in 5 years?
Well, for me, I think digital care gets me access to patients much further than our geography may limit. And the challenges of getting to New York City, where I practice, that certainly presents a lot of challenge. But also there's a number of things that can be answered in relatively straightforward ways so that patients can move on with their lives and move on with their treatments without me being the rate limiting step. So I think that's where we can scale care so much faster, allow them to interact so much easier. And if we just take a simple concept of appointments, just getting digital appointment software has made it so much easier than calling and speaking to long, holds and so forth. So I think at a basic level, that's where I'm most excited to just expand and improve the quality and timeliness of care.
Actually,
Yeah, I want to just add on to and echo what Neil did say. That I think, telehealth, for example, right? Most of us on this call have adopted telehealth. It's a game changer. Being part of a large healthcare organization, it's allowed us to kind of centralize and help patients navigate care throughout our vast geography and reach people we would never have. The other thing that I'm actually very excited about digital transformation here, in general, and in a lot of what you've discussed, Rachel, is that it allows us to differentiate our skill set. And what I mean is that, everybody here on this call is in the Metro New York area. Although we're all very well-trained specialists, there's somebody right down the street that can do many of what we can do. And staying on the cutting edge, and many of the things that you've discussed, and offering that differentiating care to our patients, I think it's very important, and it's transformative to kind of ensure that we're offering the most up-to-date care that's really digital too.
You asked about where we'd like to see it. I believe where we'd like to see it go. I appreciate, as I alluded to before, like the data aggregation part to it and having the patient interact. Some patients are more eager than others. But whatever treatments we provide, right? Perhaps how, like, whether it's medication or a procedure or some therapy, and have patients interact with, okay, over time and treatment, how has their care evolved? and letting us see, whatever it's a graph or something like that.
Data story.
Being able to look at that before interacting with the patients. Hey, look, these are the trends I see. Is that consistent with, how you experience it? I think that's the most exciting thing that I can see, coming
Well,
out of it.
Good news, Dr. Lascaridis, you don't have to wait 5 years for that. We do that right now, and a lot of other tools do that right now. But
Wow.
I think as the data set grows, we can actually start looking comparatively, which is really exciting. So going into treatments, understanding how a patient that looks like X, Y, and Z, who've had previous experience with X, Y, and Z, what are the factors that help determine better success rates? I think that's where a lot of digital tools and data sets are really thrilling. I have one last question I see that just came in, and then I will let everybody relax for the evening. But if you were an engineer, if you were a software engineer, if you had your own startup, if you weren't a doctor, and you could design something that you said, if I had this, I would deploy remote care tomorrow, right? Like if I could build this myself right now, I would do it because that's so valuable. And maybe it's an answer that you already gave, and so no pressure. Also, I'm not asking you to become a software engineer right now, or I would steal you for my company. But just is there something that like sticks out to you as like an obvious, I've been just, and pretending again that there's no red tape, there's no time for FDA. Let's like be in an imaginary world right now. But what would it be? Neil, you want to start? Although
Sure. Yeah, I mean, sort of what I'm alluding to is that working in a difficult university sort of setting where there's a lot of layers to get through. I think, again, using digital platforms to grab data and capture that into my visit, my note, to make it easier to get through insurance, to get a patient to feel confident that they are actually getting advice from me as opposed to some other third party. Those are probably the two biggest factors. And then the third is, convincing the powers that be that this is really meaningful. And I think that's the biggest challenge. You and I have been working on this for years. How do we get large scale institutions to buy in without, sort of making them feel they're taking on a lot of risk?
yeah, and I think that's we talk about like commercialization and challenges that are faced around that, is that like there aren't budgets for this, right? So in order for us to be successful, we had to tap into these existing CPT codes and build out a revenue model. But do I truly believe that like that's the best source of revenue for these programs? No, I think they should have their own, like they provide clear value for care. But I agree with you. I think that until there's an even more robust payment model, it's going to be challenging in certain situations. Do either of you have something you're passionate about in this into this question?
I mean, I will add that I think and Neil touched on this, I think the real immediate next thing that digital transformation can help with is appropriately helping us triage patients, triage calls. That'll simplify our lives so much. And to Neil's point, direct us to the real important patients' needs that need our attention, because our attention is spread everywhere.
So I'm just gonna
yeah.
Oh, I was just gonna quickly open up to see if anyone in the audience had any other questions that we didn't bring up yet. If so, feel free to use the Q&A box. All right, Dr. Lascarides, do you have anything that you want to share to wrap up? And
I'm just tremendously grateful for getting more familiar with this landscape. We've been in our healthcare institution very much engaged with virtual medicine, telehealth, and it's been gaining momentum. I do sense that, patients obviously many of them or most of them are quite tech savvy, and I think it's just the perfect time for us to start bridging that gap where we have this powerful device. They have this device that can provide so many metrics to expand the way we provide care, and the catalyst that brought about telehealth and virtual health wasn't the best one initially, being what it was. So hopefully we can advocate with our voices and as groups for platforms such as this. So Rachel, on behalf of the EPA, so grateful for your support. I think we all learned a lot, and thank you everyone that's been in attendance.
yeah, thank you. And anyone who is part of this call or they have an open invitation to reach out to me at any point in time. If you like to learn more, just even from like a consultation, how does remote care work? Can it even work in my practice? Given my experience, I'm happy to provide that insight, and I'd love to hear what challenges you're facing. Like I asked these doctors here, and see if we can solve any of them. And if not, maybe we can in the future, or we could build something together. So thank you so much.
Thank you.
Thank you.
Thank you and good evening. Good night.